And thanks, Liz. So yeah, it's great that we can have this forum to kind of share about our research. And I might have taken on a little too much in my title by saying that I'm going to talk about three very large realms of research in our research group. But I also thought it would be good as a way to introduce myself to those, both in our group, but also outside of our group, to what goes on in our research program. And the central theme really is diarrheal illness. And I'll start off with telling you a little bit about myself. Saw that previous speakers had told people about their background, and I already had a slide ready. So I was born in Hong Kong. That's me. And then immigrated to Vancouver, Canada when I was 8 years old, where I attended UBC for undergrad and a master's, and then went to a place pretty different. It almost was a cross-cultural experience in North Carolina, and went to the same at Wake Forest for medical school. During medical school, I had the opportunity to do both clinical and research experiences in Brazil, Peru, and in Angola. And that really helped to shape my interest in global health. Which was shaped quite early on, even in undergrad. I had seen the burden of infectious disease among poverty, both in Canada but also overseas in other countries. And then for my residency, I was in Seattle and to Boston for a clinical fellowship, and then across the pond to Bangladesh for 4 years for a research fellowship where I trained in the lab of Dr. Fadausi Qadri, a cholera immunologist. So my postdoc was mostly in mucosal immunology to cholera. After my wife and I had a couple of kids, we while in Bangladesh, we brought everybody back to we all moved to Utah, where 10 years ago now I started my lab. So mucosal infections. If you look at the causes of death in children under 5 worldwide, pneumonia and diarrheal diseases are the top causes, and especially if you take away the non-neonatal child deaths, they are the two top causes of deaths in children worldwide, and it's really 500,000 too many children to die of diarrhea. So I don't know if any of you hear the NPR This American Life. They go in acts, and I kind of follow this Act 1, Act 2, Act 3. So they're very different acts, but they're all along the theme of tackling diarrheal diseases. So Act 1, MAIT cells. For those who are not, don't, or may have taken immunology many years ago, just reminding you, our immune system is split into innate and adaptive, but then there are the tweeners. They're the cells that have both properties of innate and adaptive, and these MAIT cells are one of these in-betweeners. Now, why am I interested in these MAIT cells? Just the special thing is all these T cells, and in our room today, we have many people much more familiar with MAIT cells, even than myself. But just to remind you that there's classical T cells, so they're activated by peptides. So when you think of tuberculosis, like interferon gamma test, or the T cells against flu or SARS-CoV-2, you think of peptides, like the spike protein that T cells recognize. But these MAIT cells recognize a riboflavin derivative, so like a microbial metabolite. And so when I heard about these cells, and I was at a conference presenting on cholera research, a roommate at this Gordon conference said, MAIT cells. And I had it, and I was glad he told me about these MAIT cells. And so just a little deviation from MAIT cells to introduce you to cholera. Cholera is an intestinal infection of global importance. This is a bucket of stool from a cholera patient that I And in the wards in Dhaka, Bangladesh, we would have 500 admissions a day for cholera, and so you would just walk down the row of beds, and under each bed is a bucket, and you would see this. It's rice water stools. So it causes acutely dehydrating diarrhea. It's endemic in 50 countries, 3 million cases a year, 100,000 deaths at least. This is estimates. The best correlative protection, and this is important because we're going to get into vaccines in a little bit, is a virucidal or a neutralizing antibody response that's very closely correlated with anti-polysaccharide antibody response. Same kind of polysaccharide as you might see in a strep pneumo, so in the pneumonia vaccine. And there is a good oral vaccine available. It's pretty cheap when made available through the WHO. But the problem is that the efficacy and effectiveness in effectiveness studies, it's much lower in young children. So about half of that than for adults or older children. And it's probably because kids cannot mount good polysaccharide responses. So one of the reasons why I got into MAIT cells is because I wanted to improve this. And so as I told you, I was in Bangladesh for 4 years in a diarrhea hospital. So this is Bangladesh. Its capital is Dhaka, and there's the Dhaka Hospital of ICDRB, where you see just rows and rows of cholera beds, but they're really diarrhea beds because this setup is you see this bucket. There's a chute. There's a hole in the bed, and there's a chute down into a bucket where because your stool output is up to 1 liter an hour, you just can't get up and go. And a lot of people they can't get up because they're so dehydrated. So there's a way to measure the amount of stool output one has. And I worked with an incredible group of immunologists that this room was 1 floor up from the diarrhea bed, and it literally took 2 minutes to walk from here to here. It's a little farther now because they've made it from a 3-story to a 10-story building, but still it's just upstairs. And where there is something called a FACS area 3, where it can sort out immune cells and do flow cytometry. And I trained alongside these students and technicians under the same PI who's a Bangladeshi PI at this diarrhea hospital. This is the collaborative group. Include this because this is both the Boston collaborators and the Bangladeshi collaborators, and a lot of the staff, what we call hospital staff or field staff, that collected a lot of samples. Anyways, back to MAITs. So I was interested in what MAIT cells do during cholera, and do they have anything to do with the antibody-mediated protection against cholera? Can we harness these cells to make better vaccines? So one of the studies we did was we just took several, I think it's over 60 patients with cholera. We took their blood cells out, so PBMCs. We made sure that the stool cultures of the patients were indeed positive for cholera, and we obtained blood over a 3-month period. And actually, this cohort that we had, we were collecting blood for up to 2 years out. For those who want to geek out on the immunology, these at that time we defined MAIT cells as V alpha 7.2 CD161 high. And so there were a couple of findings. One was that MAIT cells are highly activated at day 7 of cholera in both adults and children. So good, they're active in children, both adults and children. And which is really interesting was that the LPS responses. Remember, LPS is what's responsible for protective immunity. It's actually not the cholera toxin antibody that's responsible for protective immunity. So what the antibody response that matters was correlated with MAIT cell frequency, which is really a neat finding. And so then we also wanted to see, well, what about MAITs in the gut during cholera? So we took adults. We couldn't look at kids because ethically kids, if you just couldn't get do it with enough safety in kids. We biopsied adults with cholera at 2 time points, and then we used flow cytometry and immunohistochemistry. We looked at their MAIT cells. We found that actually the MAIT cells in the gut were even more activated than MAIT cells in the blood, and that acute is much more abundant than convalescence. So we found that there was correlation between MAIT cells, I should say associations and correlations, and another group had seen that with Shigella. So this led us to dive into what is the effect of MAIT cells on B cell differentiation? Because most of our vaccines depend on B cell activation and formation of memory B cells. And so we want to look at this. So, and also in some monkey models or primate models, the same thing was found. Okay. And for those of you who are not into immunology, I'll get to the epidemiology quick, but in Act 2. But what we found was that when we stimulated these MAIT cells with E. coli, we also stimulated with cholera, and not a big effect. But when the bacteria stimulated MAIT cells, we saw that these MAIT cells made factors, cytokines that also activated B cells. We're really excited, and we found that this was in a done in a what we call an MR1 dependent manner. So this has to do with the way that the antigen presenting cell, there's only a special kind of receptor that the antigen presenting cell interfaces with the MAIT, and when you block it, we didn't see the response anymore. So it was a pretty MAIT specific effect we found. All right, and this, and then skipping forward quite a bit through about 5 years of Owen and Shuby working on some MAIT cell in tonsils and then in the blood, and seeing a specific subset of MAIT cells that could help B cells. We wanted to show that in an animal model that this animal didn't have any T cells. When we transferred MAIT cells into that animal, so what would happen? Do these MAIT cells on their own, without the help of other T cells, make better antibody responses? So here's the answer. I'll walk you through. This black is, again, all these except for the yellow. The yellow are normal mice, which we infected with cholera. The black is T cell deficient mice, which we transferred MAIT cells in, then we infected with cholera, and then the red are T cell deficient mice we didn't transfer. We just transferred some sham. We did a sham transfer. So you see that in black, the transfer of MAIT cells really induced these B cells to expand. And then this one is the black again is the IgA. And at 40 days, we were able to see the IgA levels the same as, remember, yellow is normal mice given cholera. So we were able to rescue this cholera-specific IgA antibody response. All right, so that's just the first act. And I got through it great in 15 minutes. So MAIT's first conclusion is that MAIT cells are innate lymphocytes activated by a microbial vitamin B synthesis pathway. They're activated in human cholera and are correlated. Just see if I can get rid of this thing here. With polysaccharide-specific antibody response. And then MAIT cells have the capacity to provide B cell help, and that we showed in an animal model that they indeed are able to promote cholera-specific antibody responses. Now, that just means that they have a potential to be harnessed to make better cholera vaccines, especially for children. But we are far from really proving that. And Shubi and I have worked, and others have worked on, well, can we link the MAIT antigen to the cholera polysaccharide? And that is proving that it's very difficult to do, but we're still working on it. But just some acknowledgements, people in my lab, people in Bangladesh, in Boston, and funding from the NIH. All right, Act 2. So cholera Sero-Epi. All right, so there's the WHO, this Global Task Force for Cholera Control, has a roadmap to ending cholera by 2030. Man, that's ambitious. And why is it ambitious? It's because there are several challenges that needs to be overcome. First is a lack of access to clean water and sanitation. Easier said than done, especially in areas of conflict, right, or natural disaster. And inadequate vaccine supply. So again, good cholera vaccine, especially in adults, but if you don't have enough vaccines, you have to prioritize, and then who do you prioritize? As I mentioned, young kids just don't have good protection after getting the vaccine, even after multiple doses. It's hard to identify, if you have a shortage of vaccine, how can you identify key populations at the highest risk? How do you target, or even if you want to give clean water to some people, like, or give chlorinated water, or promote a hand washing or wash intervention, how do you identify key populations when surveillance is so difficult? And then there are very limited methods to determine if these interventions are working to reduce transmission. So just a couple of examples. Yemen had unfortunately, a very large cholera outbreak. But when your clinics are bombed, how do you keep track of where cholera is and how much there is? Or in Haiti, which even if there was not a war or gang violence, these are mountains that are just the closest cholera treatment center is actually, I'm standing just like down the road from it. But if you live in this valley here, you have to go over this mountain, down this mountain, and then up here. So it's many days of walking. So how do you know if there's cholera in that valley where people might have died before reaching your care? So some of the obstacles in the surveillance is that if you rely on clinical reporting, and a lot of times you just can't confirm microbially because there's no culture facilities, or the health system just is not structured well enough to really have laboratory confirmation. It fails to capture non-medically attended cases, so those who don't end up going to the clinic. And it fails to capture spatial and temporal, so where the disease is specifically, and then when it started. So you might have some people trickle in from a village, but when did that outbreak start? So how do we improve our estimates of cholera exposure and risk in a population? So one of the ideas is to use antibody responses in blood. Now, again, that's if you're able to do a surveillance of and sample households in various areas, you can wait until the conflict is over, or you can wait for a break in the battle, or you can do so after a natural disaster in a way that you don't have to find all the cases, and also you don't have to culture the bacteria or somehow use an assay to detect it. So one of the ideas is to use serosurveillance strategies, but what is needed for that is we need to know what antigen, like what test to use, what antibody test. There's a lot of different antibody tests, and what antigen or what and once you know the antibody, how quickly does it wane, right? So if there's an antibody response that wanes in 5 days, you're probably not going to capture like any cases, right? Because you're probably not going to get a signal. If the antibody doesn't wane at all, well, you might capture everybody who's had cholera any time in their lifetime, right? So somebody got it when they're 3 years old, but they're now 46, and there was an outbreak. But so we're looking for an antibody response that goes up and then down. And we're looking for a couple of different patterns. So maybe one antigen that goes up and comes down slowly, and one that goes up and comes down faster. But what we found out was that using a couple of different methods, but the virucidal antibody titer is probably the best prediction of time since infection. There's a couple of ELISA methods that, when combined, does almost as well as the virucidal. But you go, well, you still need to get the blood. You still need to bring a needle around. poke somebody's veins and then store the samples in a certain way that's biohazardous. So a few years ago, Anita Iyer in our group looked at the use of dry blood spots. And she showed that even with dry blood spots, you can do neutralizing antibody assays. So just a demonstration that we can try to get good immune measurements kind of even without a full lab. This is just to show that we applied these findings, these kinetics, to a national service. So each one of these, and I guess those on the, all right, I guess it doesn't come on the screen very well, but each one of these is, there is a serosurvey site that represents that area. Okay, so they've been selected that they represent the population in that area, and the households in those sites are selected representatively. And we were able to build a map of the implied infections per year in each area. There's clearly hotspots, like in Dhaka, Chittagong, and Khulna, and those are the major cities of cholera. So we were able to use our immunology to interpret the burden of cholera in a country. What about in Africa? So all these kind of estimates of incidence on serosurveillance have relied on, and that rely on kinetics antibody responses, have used our study in Bangladesh. So one of the goals, and this is in collaboration with the University of Florida and a couple of NGO groups in Goma, DRC, is to figure out whether these antibody kinetics are different in Africa, and DRC only one location in Africa, but is actually quite an endemic area where compared to Bangladesh, which is what we call a hyper-endemic region. And so Kylie and Carmen and Christy work with samples collected by Felicia and Maisha in the DRC, as well as several others at the University of Florida, to look at kind of this decay curve. And what we found was, like in Bangladesh, the highest titers were within 2 weeks of onset of symptoms. But interestingly, most had returned to baseline by 3 months. So it indicates that perhaps in different areas of the world where the burden of cholera might be different, the kinetics could be different. The other thing about this cohort is that there were many more kids. The average age and the median age was much younger than the cohort in Bangladesh. So that may have something to do with it. Kids likely have a faster decay in their antibody rate. All right, so the conclusions from Act 2, current clinical surveillance for cholera is inadequate. Study of antibody kinetics can inform how we estimate disease burden, such as recency of cholera exposure. That, however, these kinetics may differ between rural regions or endemic level endemicity. And we are trying to develop better point of care or field assays to measure these antibody response, because right now you collect the serosurvey, they ship it to a lab, and a lot of countries where there's cholera may not have it. In Bangladesh, there's an amazing lab to process samples. Places like the DRC, which has both natural disasters and conflict, may not have the laboratory facilities. All right, so for that, I'm just going to show acknowledgements, not a list of names. I'll just show some pictures. So in the Bangladesh MGH group, in Haiti, we also work with a Haiti group, and it's GESCIO, and then Institut Pasteur in Ho Chi Minh City, Institut Pasteur in Cameroon, as well as Johns Hopkins in Florida. Again, funding from the NIH. All right, last one, and this is probably the longest segment of the presentation, is tackling diarrheal disease through mHealth clinical decision support. All right, so if a 2-year-old boy comes to your clinic with diarrhea of 3 days duration, does he need an antibiotic? What would, as a clinician, or maybe as a parent, or as a sister, or a brother, or you wonder what goes into the decision, right, of whether the doctor gives an antibiotic or not. What else might you want to make that decision? What if your clinic is not in Utah, but it's in Dar es Salaam, Cape Town, or Tokyo? Okay. Does it matter if this visit is during January? In Utah, it's the rotavirus season. So or July, where it might be like E. coli season. So just a bit of pediatric diarrhea management. The mainstay of management is rehydration. And around the world, the WHO guidelines, which I've pasted here, you don't need to read it, but it's mostly empiric. So you don't test, you just, right? Does the child need an antibiotic? And you may follow the guidelines. So WHO has a guideline that says, give an antibiotic when either bloody diarrhea is going on or there's a severe dehydrated child and is an area that you may suspect cholera in, which is in much of the world, that there may be cholera. And so if a child is 2 years older and there's cholera in your area, you give an antibiotic for the cholera. But while you give the antibiotic for cholera, there's a lot of other children who doesn't have cholera that ends up getting antibiotic because it means severe dehydration and child under 2, or sorry, child over 2. And so the adherence rates really vary across settings. I mean, this is not just internationally. I mean, you look at Utah and you see who goes according to antibiotic prescription guideline. There's a huge variation according to doctor, clinic, and also family expectation, right? So one of the questions that, or the goals we had was, can we use clinical prediction and smartphone apps to help with antibiotic stewardship? Well, because viruses are among the top causes of acute diarrhea, if you give antibiotics for viruses, you end up having unnecessary use, side effects, disruption of microbiome. And these kids, a lot of their microbiomes are already very much disrupted. And maybe clinicians, if they knew there was a high probability of it being a virus, they would not give antibiotics. So maybe some of you may know all the steps to developing a clinical decision support tool, but I'll just go over the steps for those of you who are wondering. You start with derivation and cross-validation. So you make the rule first, okay? Sorry. Yeah, you make the rule first, and then with one data set, then you validate the rule with another data set, separate data set, hopefully from outside of your clinic, the same place that you did your first data set. Then you design the support tool, whether it's an app or a piece of paper, an algorithm. Then you model how it might impact what you're trying to impact. So for us, it's modeling how many antibiotics you might stop and necessarily use. And then you implement it in a trial. There's many others, little steps in there, but that's the main steps. And so our goals were to make a clinical prediction rule for cause or etiology of pediatric diarrhea in low middle income countries, and then to build an electronic tool like an app with data sources appropriate for use in these settings, and then to implement it in a randomized trial. And so the next 20 minutes or so, I'm just going to go over how we did that. So the first objective, what we did was we used a very large data set. GEMS is a 7-site, 7-country study that took over 4 years to do, enrolled moderate to severe diarrhea, case control. So tons of kids were enrolled, like almost 10,000 kids with diarrhea and 13,000 kids without diarrhea. Every single kid got a stool sample. So this is over 20,000 stool samples. There were over 1,000 variables collected for every single kid. And the great thing was, with those stool samples, they did a 32 pathogen qPCR with TAC. And the great thing is this is case control. So it's not like, oh, you have a biofire result and you get, 4 different microbes positive. You actually also have the kid from the same village, same nutritional status, same age, and there's like 3 pathogens on that multiplex PCR. And so you can compare kind of what the excess pathogen, and this is all quantitative. So, right, so it's not just positive or negative, it's a pathogen there or not, TAC, you can say, well, this pathogen was there with a CT value of 10. All right, like you can actually quantify how many organisms there is or how much pathogen there is compared to the control. And so we were able, with a case control study, to figure out for each child what is the most likely cause of their diarrhea. So these are the 7 sites. So mostly South Asia, and then both East and West Africa and Southern Africa. Well, so we use machine learning methods, random forest, to reduce from, well, we went from 1,000 variables down to 150 variables just by data wrangling methods and some criteria. And even with 150, we were able to reduce it to the top 10 that predicted that the cause of the child's diarrhea was a virus. And then we used logistic regression to figure out the direction. So, for example, age was associated with the older age was like lower probability for viral, but blood and stool makes being virus very low. But if you vomit, it increases your probability of having a virus. Or if you were undernourished, so HAZ score, so kids who are stunted were more likely to have virus. So we kind of calculated a score, or an algorithm to predict viral etiology. Oh yeah, and the other cool thing is season, right? Season, and it makes sense to everybody. You know, in the winter when it's dry and cold, people go inside. You end up getting more rotavirus. Certainly, what we see in Utah. But it's interesting that in 7 sites, when you combine all of them, the dry and cold season is by far the most likely to have, a viral cause of the diarrhea. All right. So then what we do is we make an AUC. So it's a discrimination. How well does this rule work? Well, this metric, which goes between 0 and 1, is 0.82. So pretty well. We can predict with pretty well accuracy between viral and non-viral diarrhea. And we were able to do that with, look at the AUC and the number of variables. Even with 4 or 5 variables, we got pretty good idea whether a kid has viral diarrhea. Okay, so that's the first one. So we were able to derive and cross-validate a clinical prediction model for etiology of acute diarrhea. And the top predictors were, as I mentioned, age, blood and stool, vomiting, nutritional status. It is one of the first studies that has shown that many studies have shown that diarrheal illness is seasonal, but we were able to show that it can be used as a predictor. And then we this is a publication, and then we thought, well, maybe we need to put other location specific. So we talked to some of the doctors there, and several said, well, I don't follow WHO guidelines because it's for the whole world, and I live in Bangladesh, or I live in Mali, or I live in Cameroon, and this doesn't, how do I know that it applies to my child here in Bangladesh? So I thought, well, what if we put in location-specific parameters? So many of you, I don't have this example here, but many of you know who work in the clinic use prediction rule, like the TIMI score, or the Syndrome criteria for strep throat, or the Ottawa ankle rule for when to get an imaging on an ankle, or in pediatrics, there's the forgot what it's P-Carn's CT rule or something like that. When to get a head CT on a kid who's fallen, right? All those are almost always based on the kid's exam. So like you might assess their heart or lung or their abdomen, or their history. So did they come in with blood, or how long they've been having diarrhea? But really very few have incorporated location-specific parameters in the prediction rule. And in infectious disease, it very well could matter. So Ben Brent, who's a assistant professor in epidemiology now, was working with us as a postdoc, and so we took these ideas. So clinical presentation, just a presentation, AUC is 0.81. What if you just took historical rates? So you took the same site. So let's say you're working in Kenya, and you're in July. What if you just took the last 4 years of how often a kid comes in with a virus in July in Kenya? You can actually make a decent prediction of whether the child you have in front of you is having a virus, based purely on historical rates, okay? If you looked at climate analysis, so the climate is temperature and precipitation, remember dry, cold. You just took those two variables, precipitation and temperature, and the lag, we did like a 2-week lag for the past month, with a weighted lag for the past month. You got a decent prediction as well. What didn't work as well were recent patients, like if the last 20 patients come in with vomiting and diarrhea, this present kid, it doesn't predict as well what this present kid had a virus or not. But whether we combine all these things, could we make our prediction on just the patient better? Okay, and the answer is kind of. So first, we wanted to figure out, well, how do we integrate all these different data sources, right, flexibly? And I'm sure you have this equation in your head already, but in case you didn't come up with it, my daughter read this Bayesian probability textbook, no, she didn't. But have you seen this Bayesian probability for babies? It's like an amazing book. It taught me Bayesian. No, actually, Ben came up with this. So what it is you use a pre-test odds of historical odds of viral etiology or recent patient presentation, and then you multiply it by any kind of test or module such as climate or seasonality as a likelihood ratio. So you sum these ones up and you combine it with the pre-test odds. And the reason we did that is because not every site would have recent patients information. Not every site might have downloadable climate data. And so we want to be flexible about like which of these can be incorporated. And so the modules is flexible in that way. And so what Ben showed was that just for the present patient, you have an AUC of 0.81 or 0.82. And then, but if you combine any with the present patient, any other kind of location-specific data source, you get a better prediction. And so we kind of published this, and we're using some of this strategy now. All right, so the next step is to validate this clinical prediction rule. And what we did, and why do we need external validation? Because the prediction was internally cross-validated, resampling from the same cohort. You were using data from, at that time, about 10 years ago. And so we want to use more contemporary data. And then the prediction algorithm was developed only computationally, and we really wanted to kind of test its use in a real world setting. Okay, so for external validation, we used data from the Vaccine Impact on Diarrhea in Africa study, VIDA, and we actually showed that we achieved pretty good, almost like once you combine it with seasonality, it achieved the performance very similar to our derivation data set, which means that I think our algorithm or our prediction rule was at least kind of validated on one other data set and gave us a little more confidence. So now we're building the app. All right. So how did we design it and how did we build it? So first, we were looking for easy to use interface. So we didn't want a doctor to have to write in 40 parameters of the child, maybe 3, maybe 4 for data entry. They may only have 2 minutes per child, okay, in a very busy clinic, amenable to new or changing data sources, and then transient internet connections. The other thing we did was we did some qualitative studies, and this is under the guidance of Dr. Melissa Watt, who is in our population health science department, and collaboration with Mami Keita in Mali, in Bamako, and Debashish Biswa in Dhaka, Bangladesh. And so we interviewed a whole bunch of physicians about, well, what are you looking for in a smartphone? And these are very preliminary interviews. We've now since gone much further into these, exploring these in focus groups. And but they came up with, well, it's great when there's standardized protocol. I have an app, every patient can use it on. It makes it more efficient in terms of hemming and hawing about a certain patient. But there are barriers. Maybe we don't want it. Some didn't want to use it for clinical decision making. Some felt that it would just increase their work. They're already busy. examining a child, and now I have to pull out my phone and like do a calculation. Some just didn't have smartphones. And then some said, well, it's not going to matter at all. My patients just are looking for antibiotics, and it's not going to matter what my smartphone says about it. So, so those are some factors we need to deal with. So what we did was we used an existing rehydration calculator that was previously trialed for pediatric diarrhea in Bangladesh, and this is with that these two investigators, so Ashraf Khan in Bangladesh and Eric Nelson in Florida, had already done one study and then one randomized trial using this app for rehydration, right? So not for whether to use antibiotic or not. So what we did was we just built a prediction module, a etiology prediction module into that app. That the user entry was age, sex, MUAC, which is a mid-upper arm circumference, bloody diarrhea, vomiting, so presence or absence of each. So because not everybody has internet all the time, so it was just a nightly download of weather, temperature, and precipitation from the nearest 5 weather stations, according to wherever GIS was they were on that night. And then prior patients was data from previous patient entries at the same site, not necessarily for the same phone, but from the same site's phones. Okay, we gave them phones for this trial. So I'm just going to play this and this will work. Yes. So it's just this is both in English and French. You enter the age, you pick the sex, you enter the MUAC. They already give you an estimated weight. So this part is part for our etiology prediction and part for the rehydration calculator. This part is definitely all about rehydration calculator and just a little bit of a. I think we're looking at AI to automate that, but hopefully you can get a grant on that. And then you put in all that, and then it'll say, okay, this child has a 70% probability, okay, of there being of it being caused by a virus. All right. Now, we gave them probability because we didn't want to tell the doctor what to do, because doctors don't want to be told what to do. All right. They just want information. So this says, okay, if you're a doctor and the kid in front of you, they have a 70% probability of the diarrhea being caused by a virus, you may or may not decide to give an antibiotic, but you have more information also to show the parent. All right. So, okay, these are some screenshots. So we took it to the clinic, and we did first an external validation on this cohort. Okay, 5 more minutes. And then we did a randomized trial, and we did both of these under a collaboration with the CVD Mali group in Mali and ICDRB in Bangladesh. All right. So the external validations, we kind of went back and did another validation because we just want to make sure again, since we're going to be telling doctors kind of information and we want to be certain of that information. So we did, again, in the year right before the app trial, randomized trial, we did another external validation where we actually did the TAC ourselves and estimated the probabilities. And we found that there was a pretty good accuracy of the smartphone app that combines these kind of patient and location specific factors to predict viral cause of diarrhea. And so then we did an implementation trial, and this is only possible because Gates Foundation funded this. Actually, they funded both the development of the app and this randomized trial. If you want to hear more about getting interfacing with Gates and their processes, happy to share at a later point. And so we did this. You notice we built the study and we got funding in 2019, and we started it right around the time that the COVID-19 pandemic started. And it's really credit to the teams in Mali and Bangladesh that we did this all over Zoom. So 30 physicians were recruited over 7 sites in the 2 countries. And what we compared was the rehydration calculator alone, so without the module of the prediction, etiology prediction, and then the calculator with the prediction, etiology prediction. We did this randomized crossover with a 1-week washout. And then we also enrolled the children because we wanted to call them back and see how they did. So we enrolled both 30 physicians and then several hundred children, which we followed up by phone. Well, we followed the caregiver by phone after 10 days. And the primary outcome, which I'm not sure we would have chosen it looking back, but we pre-hoc said proportion of children prescribed antibiotic. That's what we cared about. We actually cared about more than that. So we screened over 2,000 patients in the two sites, and we enrolled around just under 1,000 patients, and for the 30 physicians. The primary outcome, it was a dull. So it was that there was no statistically significant difference in how many children got antibiotic in each arm. However, when you look back at it, when you actually didn't just see antibiotic or not, we saw that if there was a 10% increase, for every 10% increase in predicted probability of viral diarrhea given to the doctor, there was a 14% decrease in the odds of antibiotic prescribed. So actually, there was a signal. There was a signal of that the more information the physician got that it was a viral diarrhea, the less likely they are to prescribe antibiotics. All right, and then thankfully, and I think we were actually, we wanted to know that there was no difference in patient outcomes. So whether the kid was in the etiology prediction arm or not, there was one death in each arm, and we actually got follow-up data on over 96% of the children. All right, so I'm just going to end. I think we're going to have 10 minutes for questions. We derived and validated a clinical prediction rule for prediction of viral etiology for diarrhea in kids. We developed a smartphone app with a couple of different innovations. We used both patient and location-specific data streams. We had dynamic and real-time updating of climate data and recent patients. And we had an output of a probability-based estimate. We didn't have a directive, and I think that's important for a couple of different reasons. And then we completed a randomized trial to show this potential utility. Lots of people were involved. Melissa Watt on the qualitative aspect, a lot of stats help from Ben Brins, Tom Green, Ben Holland. I will say, and then people in Bangladesh, Mali, and several partner institutions in the US. I think I do have some time. I'll just say that this work would not be possible without NIH funding, and it really is. I was lucky to get 3 R01s fairly close to each other, all of which were in investigator initiative. I did not go for an RFA, and I think I've been asked, like, should I just wait for the RFA? We had ideas and we wrote them. And the RFA that we did get was one of this R2133, which is to look at mHealth in village doctors. So the R01 we did in clinicians and physicians, in Bangladesh and Mali, and then the R2133 was for village doctors in Bangladesh, which is informal health providers in villages. All right, and thank you. This is a gathering of our group plus former members of our group plus my family's in the middle there, and I think there's a lot of support that I would credit my family for. So that's all. I think that was a lot of stuff that I went over, but happy to take questions.
I guess I have a question. There are some concerns, whether founded or not, of dramatic changes to like NOAA funding, and then would that potentially impact the ability to use this app in publication?
Yeah, so the NOAA weather stations are in all over the world, and there's a network, and I'm not sure. We've also used NASA weather station model data, which is harder to do because it needs to be modeled first. So like nightly downloads would not be possible. But I do think that kind of this seasonality, directly observed data from NOAA stations you can also replace it with just like a sign close sign, estimated seasonality that doesn't do as good a job, but pretty close. Yeah.
Did you ever look at the parasite burden for diarrheal?
Yeah, so in GEMS, they looked at Giardia, for example, and Giardia actually was protective of diarrhea. So it was, diarrhea was not attributed to Giardia because it was protective. Cryptosporidium definitely is a cause, but the problem is that if you look at crypto, its treatment is so different. Even if you believe there's a treatment for it at all, a drug treatment, that it's not very actionable. So for the doctor to know, okay, there's a protozoa. But yeah, I think I've looked. I think we can get a better use case of how to use that information. We could probably do. We did a very. I think Sharia did a very quick look at can you predict cryptosporidium, because it is a pretty common cause of acute diarrhea, especially actually in both African and Asia sites. But I think it would be hard to say. Well, okay, we know it's cryptosporidium. But it's like, now what do you do with that information? Because there's no drug for it. And helminths in general are not causing acute diarrhea. They're probably more likely to lead to growth problems and so forth.
Is the app currently available, or like the hope to be available in most languages?
Yeah, so our hesitancy of putting it on a Google Play Store is because it's validated in Mali and Bangladesh. And if people want to use it outside of that, I'm not sure. I'm not very confident that, well, it likely work, but we haven't validated it. But there are apps out there which have not been validated in anything for people's use. So there's an argument that you should just put the app out there and have the information available, but we decided not to do that. Yeah. Catherine?
Oh, such a great talk. Incredible work. I'm wondering if extreme weather events associated with climate change are also linked to cholera outbreaks, or sorry, diarrheal infection outbreaks, and if that is going to play a role in future apps.
Yeah, so I think what it would change is kind of the way the seasonality is, maybe with more hotter temperatures, therefore the incubation of bacteria is easier, especially in these ponds or water storage locations. So our kind of lag of temperature may help with that. Like when we are able to put temperature with the model, but the events themselves, we haven't really, dug into that. That's a potential direction. Yeah. Thanks, Mary.
Just related to the question, do you have plan to connect the oral diarrhea with the notification for the future?
You mean like do the Sero-Epi for another disease?
Just connecting consequences with oral diarrhea with the notification.
Yeah, I mean, I guess with what kind of disease are you thinking?
I don't know, maybe some another gut diseases, gut-related diseases.
Yeah. So we know that cholera, we don't know the long-term effects of cholera as well. We think most people recover from it pretty completely. The microbiome changes, but then it goes back to normal, probably goes back to pre-cholera kind of distribution of microbes at 30 days after cholera. So I think it's less likely that somebody is going to have the pathophysiology is going to change long term, but cholera can take people out of work for several days, and that's probably a bigger impact on health outcomes after cholera, because if you lose, let's say you make $2 a day and you miss 5 days of work for cholera, that's $10 down, and that might mean part of your family goes hungry for a few days, right? So that's probably the more impactful part, more than kind of the gut, because but there are other diarrheal disease that cause more gut inflammation, like Shigella or Salmonella. But that, right? So we've looked at kind of respiratory illness after intestinal infection, or even some autoimmune diseases like after Campylobacter infection. But for cholera, it's likely that the socioeconomic impact is greater than the biological impact or pathologic impact. Yeah. Anybody online that has a question? there's a chat. I don't know if you can pull up the chat. No. Can you see the chat? Or I can't see the chat, so.
There aren't any questions.
Oh, thanks. Okay.
So I took a look. Thank you, Daniel. I thought it was a fantastic talk, just as a surgeon who's completely novel to this area. Thank you for making it simple enough for even the most the most non-ID experts in the group to understand. Oh, it looks like there's just a couple of questions that just came in, and I can't find them now.
Oh, I see it now. Thank you. Sudha, thank you. I appreciate those comments. It's just like when you presented your injury work in a way that I could understand. That was great. Yeah, so is there a way to identify carriers of cholera? Oh, that's a politically fraught topic because as you recognize that that's how Haiti likely how Haiti got cholera in 2010. It was because peacekeepers from Nepal came. So there is there's an RDT, so a rapid diagnostic test that would pick up cholera in stool samples at a certain, I think at a certain level. PCR is more sensitive, but harder to conduct. So the answer is yes, there are methods, but the feasibility of doing that, so testing asymptomatic people who are going somewhere, who are traveling, I think is going to be really tough. And you know, as you know, there's a lot of travel between countries, and we already deal with kind of some of the both political, a lot of political problems with travel between countries, and identifying carriers of a pathogen that may not impact that person, but can very well impact others. So there are ways, but it's hard for me to figure out how exactly that would ever be able to do. I mean, so antibiotic resistant bacteria are imported by many of us who travel internationally back into the US, or there's other examples as well. Typhoid fever and carriers of that imported in the US. But it's the Haiti situation is a reflection of both the importation, but also the earthquake that just had happened and the destruction of infrastructure of water and sanitation. So it was kind of a combination of two things that happened within the same year and that were related. Okay. Well, it's 1 o'clock. Thanks, everyone. I think 2 weeks from now, Bobby Mohanty is giving a talk to us, so in this forum. So, thanks.
Daniel, could you talk a little bit about what Bobby is going to talk about?
I think he's going to talk about diagnostics for TB.
I was wondering that. I was like, his last name looks really familiar.
Like, do you know this professor I reached out to her? She's doing like research for this like awesome. Yeah.
Oh, thank you.
See that now I can see you. Sorry. I can see your face. I can just hear you.
No worries. Good to see you. Thank you for the talk. Thanks everybody for attending.
Yeah.
Sorry, I'm out of town at the moment.
No, understood. Yeah, safe travels. Thanks.
Let's see. It feels like I'm just still starting, but trying to grow it. Trying to recruit grad students is like so hard.
Yeah.
I don't know. They have one job.
Yeah. There is like
Like where
I think